Hi, everyone. Good afternoon. I'm Jessica Cothran. I'm the marketing manager with UW Medicine's Spine and Sports Medicine program. And we're going to get started here in just about 1 minute. We're going to let some more folks sign in. All right, well, thank you everybody for joining us for a webinar. This is Solving Lower Back Pain and Sciatica. We are recording this webinar and we'll share it out with you all by email later this week. We have 3 presenters. You see them on the screen here. I'll introduce them in just 1 second. I wanted to mention that we received lots of really great questions from attendees when you registered. So our presenters are going to try their best to cover as many of those questions during their presentation and right afterwards. And then any other questions that you might still have, you can post them in the Q&A feature at the bottom of your Zoom screen. We'll try to get to as many as we can in the time that we have. We have an hour. And we have our 3 presenters. So we have Julianne Krause. She is a physician assistant in the spine and orthopedics program. She works with Dr. Patel. Dr. Viral Patel is an orthopedic spine surgeon. And we also have Neelwant Sandhu, who is a physiatrist, which is also called a physical medicine and rehabilitation physician. So I am going to go off screen and let these 3 take it from here.
Great, thank you so much, Jessica. Let me just share my screen here. All right, welcome everyone. So firstly, I'd like to get started by just going over some symptoms that you may be having. Usually people come into the spine clinic complaining about some sort of back pain. They may also have shooting, leg pain, numbness, any combination of tingling and even weakness in their legs. It may just be affecting only one leg, but it can affect both, and one can be more symptomatic than the other. Usually the different activities that cause worsening of the symptoms include walking, standing for any length of time. Sometimes sitting or even lying down can be painful. Twisting and turning motions can also be painful. So why are you experiencing leg pain and we're talking about your back today? Well, I'm going to go over that in more detail, but in this image here, you can see that there's nerves that go down the lower spine and they feed into the rest of the leg. So you may be having symptoms in your legs, but the issue is really further upstream in the lower back. So we're going to be focusing on the spine today, but we also wanted to detail some other causes of back pain, which can include infection, some sort of traumatic event. Cancer can also cause back pain. Idiopathic, which means that we know that you have back pain, but there's not a really good reason yet that we can understand of why you're having the back pain. Also, other issues that have nothing to do with your lower back can cause back pain, such as kidney stones, inflammation of the pancreas, or what's called pancreatitis, a serious condition called abdominal aneurysm, or other non-spinal causes can cause back pain. So you've been dealing with these symptoms for a while, but when should you get it checked out by someone in the medical profession? We say that if your pain doesn't improve in 2 weeks, then you should probably see someone about it. This may be your primary care at first, who may do some initial workup and prescribe some treatment. And then they may also send a referral to one of us in order to take over that investigation and treatment as well. We also want to pay attention to what daily activities that may be impacted by your symptoms. So whether it's just washing the dishes on a normal day is painful, or you go out for a lovely hike in the Pacific Northwest and you're no longer able to do those certain activities, that would be a time to get it checked out. So first we wanted to go over what is normal. So these are x-rays, which are really good for distinguishing the bony anatomy. So this picture off to the left, we can see here the lower back is comprised of 5 lower back bones, L1 through L5, with the tailbone or the sacrum at the very bottom, and then the upper back starting with the ribs and T12 or thoracic 12. This is a view from the side where we can see those same bones labeled here. We can see the bones on the x-ray, but we can't see the discs or the soft tissue anatomy. But what we look for is the disc height here, and as well as some other characteristics, including the alignment as dictated by the yellow stripe, the foramina, which is Greek for windows, where the nerves exit at each level of the spine, and then the joints in the back or facet joints that can become arthritic or have wear and tear over time. So on an MRI, we can start to see what the tissue and the nerves are looking like. So this view here is a view from the side, very much like the x-rays, where we have the bones that are the squares and the space between that are the discs. Normal disc is white in the center and black at the periphery. And then along the back here runs the spinal canal, where all of these nerves, which are the black lines, are contained in a fluid-filled sac, and that fluid appears white on the MRI. We can look a little bit better at the holes or the foramina on the side, similar to the x-ray, where we see this white tissue surrounding the black dot, which is the nerve. So this looks really good here at all 3 levels. On this last slide here, this is a shot kind of slicing you like a loaf of bread this way, looking down the spinal canal. So this part in the middle is all where the nerves are. And you can see all the individual dots are the nerves, these black dots. And then these dots in the corner are nerves. And then these dots on the outside are the nerves. So depends on where your nerve compression is, can give you different leg symptoms. So a few common causes that we see in patients is a disc herniation. So the disc is similar to a jelly-filled donut, is what I like to say. But if that disc becomes squished or herniated, then that jelly is now outside of the donut and can cause some nerve compression and thus give you symptoms. Usually people with this come in saying that they lifted something heavy or they were moving furniture and they all of a sudden had some back pain or back discomfort, but it worsened either later that day or the next day and they developed new leg symptoms. So on this MRI, this person's disc at the very bottom is kind of popping out right there. And you can see on this cut that there's this little ball of disc that's right in the corner there that's compressing the nerves. Another common cause of leg pain is lumbar stenosis. Stenosis just means narrowing. This is typically something that develops over a long period of time. Patients walk in and they tell me that they have difficulty standing for a long period of time. They can walk a little bit, but then they have to sit down and then they can walk a little bit further. It usually improves with sitting and bending forward. And they may also have some leg symptoms like pain, numbness, tingling, and weakness. You can see here on this MRI that the canal is open at the top, but then at this level, and this level, all of that white fluid kind of goes away and you have nerve compression in the very center. Up here on the top right is that image of the normal spinal canal. It's nice and open. You can see all the individual dots, but on this image with the stenosis, all of that white fluid is lost in the center. You can't make out any individual nerves. It's really tight. Another issue that we come across is what's called spondylolisthesis with stenosis. So us in the medical field tend to make things more complicated than they really are, but spondylolisthesis just means a slipped vertebrae. So many causes are related to this, but mostly we see degenerative and traumatic. So over here is a picture on the X-ray of what normal looks like. You can see this nice curve here where everything is lined up. But on this X-ray, unfortunately, this person has a slip where their number 4 bone is forward on top of their number 5. And thus our gold cord is discontiguous at this point. You can also see it on the MRI where the nerves get really tight in the center right at the back there. Another issue is facet arthropathy. So this is more commonly referred to as arthritic joint pain. People come in with immense back pain, which is worse with twisting and turning and going from sitting to standing positions. Usually they don't have a lot of leg symptoms. It's mostly back pain that they're dealing with. That's why we like to take a look at the x-rays, because on this normal one, you can see all the lines are pretty clear in the back here with the joints. But on this one, they're all pretty fuzzy in the back. And so we can see that those joints are a little bit worn out. So Dr. Sandhu is going to go over some treatments and interventions that we can do and discuss this in more detail. But a general outline of how we approach the situation is we start conservatively and then move more invasive if the symptoms are not improved enough. So we like to start physical therapy, any sort of chiropractor or acupuncture care, anti-inflammatories. ICE is the most potent anti-inflammatory with the least amount of symptoms or side effects. NSAIDs or non-steroidal anti-inflammatories can either be over the counter like ibuprofen or naproxen, which is also a Aleve, or maybe also prescribed by your doctor, meloxicam or diclofenac. Depending on the issue, a short course of systemic steroids may be an option. And then we would advance to some sort of a procedural intervention, some sort of an injection, possibly. And then the last option being surgery. So at this time, I'd like to hand it over to Dr. Sandhu to just explain a little bit more in detail.
Neil, you are muted.
Okay, how are we now? Okay, thanks, Julianne, for reviewing the some of the common scenarios that we and images that we see in our clinic, and by no means are those all inclusive list of conditions that we typically see. I'm a physiatrist who's fellowship trained in spine and musculoskeletal medicine. Dr. Patel, Julianne, and I work as a team with our other surgical and non-surgical colleagues to determine what is the best help we can give to our patients with back pain. So I'll try and do sort of an overview of how I approach back pain, and then Dr. Patel will go through some more surgical details. I have no financial disclosures. I understand that this is a general overview and not a individualized medical advice. I urge you to see your spine physician for more specific back conditions, because we just can't give you an individual advice without knowing you. Low back pain is not just a source of pain. Low back pain is very common, and we see that in 80% of adults will experience at least low back pain at least once in their lifetime. Sorry, my slides are not advancing on my side, but I think you guys see it on your side. Most new onset low back pain will improve with time, regardless of treatment. Some may need short-term medical management. In some cases, pain does not completely go away and it becomes recurrent or chronic. But even in those cases, return to previous activity level is usually possible. Majority of back pain and related symptoms do not require surgery. So the aim is to treat your back beyond pain, because it's an organ that serves essential function. All your limbs connect to it and energy transfers through it, and it's the engine that drives forces. And so it's really important to rehab your back. So our goal is to help facilitate optimal function, health, and happiness and independence of an individual when we treat pain and back conditions. It starts with assessment with thorough review of symptoms. It gives us information on what may be causing your pain symptoms. We review your medical history, response to prior treatments, detailed physical examinations are done. We use evaluation with diagnostic testing, mostly imaging. But most importantly, it's really important to understand who the person is and what their specific needs and goals and challenges and responsibilities are, and how it affects the person and their well-being. So it's really important to pay attention to that goal when we're treating someone. In formulating a diagnosis, the diagnosis may not be straightforward right away or sometimes ever, but it's important to discuss this with our patients. There can be multiple factors that are and structures that are involved in causing symptoms, such as hip and SI joint and pelvic muscles. Sometimes we may not know the exact cause, but it's still possible to get a good outcome without knowing those details. It's important that we rule out more concerning things like tumors and infections and cancers and fractures and any kind of significant neurological injury. Images are not always necessary, but we'll order them if needed. Julianne went through some of the slides and things that we see. All those may or may not present with symptoms. You can have those exact MRI images that don't cause any symptoms. So that's important to realize, that we have to really correlate with how someone presents and how their examination looks. For example, you look at this slide here, there's a research that shows 91% of people without back pain have disc degeneration. 64% of people without back pain have disc bulges, and so on and so forth. It doesn't mean that those can't cause your pain, but really we have to put it in perspective before we start formulating a management plan for you, because we can do too much, and doing too much can cause damage as opposed to help. In terms of a treatment and management plan, it's important to optimize well-being and function, like I talked about. We have to determine whether non-surgical care is appropriate for you, or surgical care, or both. We prioritize well-researched treatments when possible, and sometimes the data is just scarce on it, so we don't know. And we just avoid unnecessary treatment, especially those that have significant adverse effects. But it's a shared decision-making, and we like to involve the patient and provide knowledge and share knowledge, and then make decisions together, because that gives us best outcomes. A general approach to treatment is in the acute phase, which is around 6 weeks to up to 12 weeks. We try and control pain, control inflammation, promote activity within tolerance, generally restore or at least maintain mechanical function of the back, and provide patient education. In the chronic phase, when things become a little bit more settled in, we try and promote appropriate activity and reinforce the education and restore function back to the prior levels. In most situations, it's possible, but there are barriers. There are barriers to recovery, and we have to address those and our patient concerns. So that's what happens in sort of a longer term scenario. There are many treatment options available, which can be pretty overwhelming for a patient. Some of the treatments that we commonly talk about are resting, activity modification, oral medications, modalities, manual therapy, bracing, exercise, importantly, physical therapy, injections, manipulation, acupuncture, and so on and so forth, even pain clinic referral to get help on managing pain conditions, and then surgery. There's no one superior approach. It's sort of, it doesn't mean you always need more conservative treatment before going to surgery and vice versa. It really has to be custom tailored to the individual. What works for one individual may not work for the next individual with the same situation. So there's a little bit of difficulty in giving a blanket recommendation to everyone that has a back pain issue. Various medications are considered in the same deal. We have to weigh out the pros and cons. We have to look at what the patient is presenting with, and then what the harms that can be done also with these medications. But typically, anti-inflammatories and muscle relaxants are used, and there are other medications that are commonly used depending on the situation. Opiates are generally not strongly recommended, but there's a time and place for that also. Spinal injections, we find that it can temporarily help pain symptoms. And that doesn't mean that your pain is only temporized. There are certain things that get better with time. And so we try and buy time with these injections. And epidural steroid injections for sciatica due to disc herniation seem to be most beneficial just because of how disc herniations naturally progress and improve. But it can be considered for other conditions also, stenosis and spondylolisthesis, like what Julianne talked about. There are joint injections also, and these are generally most useful in conjunction with other treatments. In terms of exercise, we got a lot of questions about exercise and what's the perfect exercise, the great exercise for back and spine. There's no perfect exercise, unfortunately, or not that we know of. There's data hasn't proven that yet in terms of the research that's been done. So it's very individualized to the patient. In terms of the acute management, data is not very supportive that any type of special exercise is blanketly helps everyone. And so it's actually not well supported in the acute phase. It doesn't mean we don't promote mobility and moving around. In the chronic phase, more than 12 weeks of pain, when we look at research, it tends to help to some degree, and it's actually one of the first line treatments for chronic back pain. The role of exercise in PT is frequently undervalued in this phase, and core exercising and general conditioning is quite favored. So it's often useful to work with a professional to get optimal results because there are many other nuances in play. Sometimes our backs have developed tension and muscle dysfunction and contractions and such, and sometimes concurrent hip issues. And so a PT, for example, can help you sort out those things before you move on to a more generalized sort of routine exercise program on your own. But exercise on its own, it's not a cure for everyone, but it's part of a multifaceted approach and an important part of it. Exercise has other benefits. You improve your strength and flexibility and endurance and muscle mass, and has cardiovascular benefits, and that's what you want. The back pain is just sort of a barrier to getting to where you want to be and enjoy good health. And it also helps promote comfort and anxieties around back pain in turn. It helps mood and sleep. So there's a lot of benefit to trying to set that as one of your goals among your other goals that you may have in life. There's many variations of exercises that are tolerated and safe for most individuals. Again, this is not saying you go out and do it. Your individual situation may be different. So not medical advice, but in general, there's different types of exercises, McKinsey and yoga, Pilates, Tai Chi. They seem to have similar types of benefit. There's no strong recommendation as one is better than the other. So whatever makes your back feel better, you can do those in general. And there's a strong recommendation that some exercise and routine exercise is beneficial as opposed to not doing exercise. So general idea when you start an exercise program is to start low, go slow, and if it's painful, see someone who does spine care. Some things we want to highlight and we won't spend too much time on is that psychological and psychosocial factors can worsen the perception of pain. Some of the things that one can work on is looking into job satisfaction, depression, anxiety, anger, PTSD, stress, insomnia, and also fear avoidance beliefs. This is a belief that movement and activity will be associated with further injury to the spine. In some situations, in rare situations, it's valid, but in most cases, it is not. So it's important to explore that to find, it's one of the facets of improving or treating your back pain. So important to explore. Risk factors, some of these you can modify, some of them you can't. Genetics, that's what you're stuck with. So you're going to get that. But things that you can work on are weight control, cessation of tobacco use, not leading a sedentary lifestyle. If you have a vigorous, active lifestyle, it may cause more wear and tear of your spine, not necessarily. So you have to find that middle ground. And then there's other concurrent musculoskeletal and medical issues that could be causing and contributing to your pain also. And that improving that and working on that can be helpful. So some take-home points, many back pain conditions are just inevitable. They cannot be prevented, but management is possible, and it's usually not harmful. Understanding the patient from our perspective and their needs is very essential. So a provider must take time to explore and listen to you and figure out if you're functioning like you want to and like you need to. Multifaceted approach seems to work best. Be cautious of someone who offers you just one magical treatment that solves it all. That's usually not the case. Pay attention to the red flags that Julianne went over. If you have any question, you can just ask your provider. You don't have to worry about that on your own. It's never too early to see a specialist to help understand your back pain. The sooner you get started, sometimes it's better to be on a better trajectory than to start late. But the goal is management. Often it's not cure, whether it's operative or non-operative, and a lot of times they go hand in hand. Understand that our spines are dynamic and they're changing, and you may have to adjust along the way. Yeah? See one of us and we can help you guide your care. Dr. Patel will discuss some surgical approaches to conditions that don't improve with non-operative management, or simply need surgical management to just start with in order to facilitate a good outcome.
All right. So thank you so much, Julianne and Neil, for your excellent talk. So I'm gonna talk more about the surgical approach for the lower back pain and sciatica. I'm a fellowship trained spine surgeon for the deformity, pediatric deformity, degenerative spine conditions, and the trauma. So usually I tell the patient I'm talking more about the degenerative conditions. So lower back pain and sciatica is mostly a quality of life issue. So it's not as long as it's not a cancer, it's not a cancer, and it's not a heart attack that you need to have treatment right away. You have to try all the conservative methods, and you can try everything. Everything fails, then I think the surgery is an option for the perfect surgical candidate, not for everyone. If you are having a pathology which correlates with your symptoms and surgery is an option, then surgery can help patients' back pain and sciatica. So I'll keep this talk as short as possible and simple. I have no disclosures pertaining to this talk. So I'll start with the most common pathology is the lumbar disc herniation. So indication for surgery for most of the degenerative conditions is if you fail your conservative treatment for 6 to 12 weeks, if you're not getting better with your back pain and leg pain. So this is the time, yes, if surgery is indicated, surgery can help. Some patient comes in the disc herniation into the ER, like emergency room, get admitted in the hospital, get the pain control, but the pain is intractable. So they are not getting better, then yes, surgery is indicated at that time. And very rarely the surgeries are indicated when you have some weakness from the compression on the nerve or quad-iconic syndrome, known as like bowel and bladder dysfunction. Yes, then it becomes emergency surgery, but that's extremely rare. But most common reason we do surgery is failure of your conservative treatment for 6 to 12 weeks. So here's the example of herniation of the disc. the patient has a disc herniation compressing on the nerve on this corner. And usually I do it surgery from the back part of the spine. So you go in here, you cut the skin there, and you dock there. I do it through the minimal invasive tube. So I dock the tube on top of the spine, and I make a little bit bore hole to get into the spinal canal, and then pluck this disc out to make room around the nerves. So usually it's an outpatient surgery and with the minimal risk of complication and good outcome. So this is how it's going to look. I usually put the tubes on the top of the spine, and then we work through the tube and make room for the nerve. So second pathology, we discuss about having a compression on the multi-level, have a compression on the nerves on a multi-level with multiple pathologies. So that's also a surgical indications is about the same, which is all conditions are same. You have to try conservative treatment at least 6 to 12 weeks to make sure you're not getting better. I think then and then is surgery is indicated if you are a perfect surgical candidate. So here's the same MRI that Julianne already mentioned in her talk about the compression in the nerves on multiple level. As long as you don't have any instability or you do not have any deformity or scoliosis, then we just go in and make room around the nerves, which calls spinal decompression, and then we without doing any fusion. So this is how we check the fusion surgeries, decompression surgeries. So X-rays on the left, you can see there is an X-ray, you have all the bony elements in the spine. X-rays on the right, we took the X-rays after the surgery, so we make room for the nerves. You can see it here. This all, I keep it wide open for the nerves. So this is just a spinal decompression surgeries without doing any fusions. So now comes to the topic when you need a spine fusion surgery. So when you have a surgery, when patient with the spondylolisthesis mean having a slippage of the lumbar vertebral bodies like spine bones in between and have a compression on the nerves, that's the time you need a fusion. So here is the MRI and X-rays. You can see from the side that you have a slip on the spine bone on top of each other with the compression on the nerves on the MRI. The goal for the surgery is to make room for the nerves, but that requires to take out some bones and half the joints. Then your spine becomes more unstable, which needs more fixation and the fusion. So this is what we did. We put the screws and a rod to stabilize your spine and try to fuse your spine. So we take the disc out, put the bone block there so that you can heal it together, and we make room around the nerves. So every patient and pathology is different. This comes back to question like it's all individualized. Your patient needs to talk to the surgeon, try the conservative treatment before. If your symptoms are not improving, then yes, surgery is an option. But every pathology has a different surgical plans. So then you have to discuss with the patients about which symptoms are going to get better after the surgery, which symptom is not, to set up expectation level. And then you also discuss about the risk and benefit and all their discussions with the surgeon. And then then you can make informed decision whether to proceed with the surgery or not. So that opens up opens up for the questions. So we'll start with the question which is submitted at the time of the registration. And in between, if time permits, we're gonna answer some questions, which is also on our Q&A box.
All right, so I think the first one that we should tackle, Dr. Sandhu, can a herniated disc heal on its own?
The short answer is yes. Herniated discs, we have to realize, are commonly seen on imaging, even in the absence of symptoms. So they're fairly common. The thought is that they can be painful when they're fresh and new. An MRI typically doesn't tell us whether they're fresh and new. And so there can be a little bit of a guessing game at that point. They can cause back pain if the herniation pinches the nerves. It causes sciatica. Many times the disc will regress on its own with time, but it's hard to accurately predict which individual will experience that. So a lot of times we'll give it time. If things heal on their own and the symptoms are tolerable, it's okay to give it time. If you're getting, nerve symptoms and damage like leg weakness or bowel or bladder weakness, then you may have to go to surgery, or if it doesn't heal on its own and it's still causing you pain. So generally several weeks to months, sometimes sooner, sometimes later, but yes, they can heal on their own.
Another good question that we got, and one that's also popping up in the chat. Can you have both scoliosis and stenosis?
Yes, both scoliosis and stenosis can present at the same time. And scoliosis, so I have one question in the live right now, is that scoliosis can cause a back pain or not? So scoliosis per se is not, its pathology does not cause pain, but the degeneration comes with the scoliosis. Like over the period of time, you have one side of scoliosis, you have a more pressure on the joints that can do degeneration on your spine joints, and that can cause pain. That's number one. Number two, with the scoliosis, your posture changes. So your muscle around your spine has to work really hard to get you straight up and stand up straight. That can cause a pain when you stand and walk for a long time. And any treatment is a symptom driven. So if the patient is up to the point that they need to forward all treat, I tried all the conservative treatment, they wants to forward with the surgery, then stenosis without scoliosis can be treated with the only decompression alone. But if you have a scoliosis and a stenosis with it, then it becomes a little bit complicated. Then also depends on how severe is the scoliosis is, how big is the scoliosis is, how many levels are you have a scoliosis. So then you becomes single level fusion to multi-level fusion with the decompression surgery. So that also it's pretty individualized. So that's, but yes, scoliosis and stenosis can present at the same time.
What about, can you speak to nerve root ablation, Dr. Sandhu?
Nerve ablation in the spine refers to a procedure for the tiny nerves that innervate the joints of the facets. We don't ablate the actual, the big nerves that come out of the spine, because doing that will cause a lot of problems with leg weakness. So that the tiny nerves that go to the joints, for arthritis in the facet joints, can be a source of back pain. Sometimes it's difficult to sort out. So if you suspect arthritis in the joints, those nerves are the nerves that pick up the painful information and deliver it to our central system, and then we perceive pain. Typically, we start with conservative treatment like physical therapy and activity modification and medications if we need to. And if the symptoms persist and the history and exam is consistent, there's some diagnostic steps that are done before doing a nerve ablation near the joint. So you put some numbing medication in the area of the joints and see if it takes away your pain temporarily. If it's successful, then you have a better chance of a good therapeutic outcome. The nerve ablation is actually done with a specialized cannulated needle that actually denatures and ablates the nerves that go to the joint. And hence it cuts off the signal, the pain communication from the joint to the brain. If the procedure is successful, you can get 6 or 12 months or more of pain relief with that.
Great. So going back a little bit to the scoliosis that we talked about, are there any specific activity precautions or exercises that people could try?
And there is another question in the live as well, that you have a scoliosis associated with the age, what we can try. So I mean, scoliosis, it's case by case. It depends on how severe the scoliosis is. but I think you can work with the physical therapist and to work on your core muscles to offload your spine. That sometimes helps with the back pain associated with the scoliosis. Secondly, you can also work on a postural exercise and balancing exercise, because sometimes, because how the spine is deformed and in the scoliosis, your posture isn't not in the right position. So if you work on a postural exercise and balancing exercise and get a better posture, that actually helps some biomechanics around the spine, also helps biomechanics around your hip and knee joints that relieve and decrease your pain and then decrease your suffering too. So yes, I think you can try some physical therapy to start with and start some conservative treatment. Try to take some pain medications over the counter if you're still having a pain. But there's other options you can try initially, and at some point, if this is not working for you, then I think you need to see a spine specialist to further workup and then further plan of management.
In that same vein of the hip pain and sciatica or SI joint pain, can you help give some pointers on how to differentiate those?
Yeah, these entities share a lot of common regions of pain distribution, and history and physical exam, sometimes imaging, and sometimes diagnostic injections are needed to sort out the sources of pain. So sciatica versus hip pain versus SI joint pain. Sciatica is a symptom. It means pain radiating down past the leg. It used to be thought that the sciatic nerve is the biggest nerve in the body. And it used to be, it was felt that pain going down the leg was an irritation of that nerve. However, the most common cause of sciatica is a pinched nerve in the low back, and pain can radiate anywhere from the back to the toes, but it doesn't have to radiate at all, which makes it confusing and sometimes can present as hip pain and SI joint pain. That's where a history and physical examination, sometimes imaging, can be helpful. In terms of the hip pain, typically it's due to arthritis. That's the most common cause that we see. And it usually causes groin pain. And on exam has some mechanical components that don't really behave like sciatica or SI joint pain. It's usually groin pain can radiate to the knee, usually not beyond that, but there's significant overlap in symptomatology. And then we have SI joint pain. It's usually focused in the back and the buttock region. It may radiate to the leg also, but then that's where the key examination components come in to differentiate. So sometimes imagings are helpful. Other times, diagnostic and therapeutic injections are helpful. Sometimes people will present concurrently with all those things that I just spoke about. And so you can try an epidural injection in certain settings and see if your pain goes away, or a hip injection or an SI joint injection, and that can help differentiate the components of pain and help you manage that.
Yeah. Another, I thought, very relatable question was if we had any recommendations on specific mattresses or shoes.
Yeah, this is pretty common question we get. So, and the problem is we have so many mattresses available in market. So it's pretty hard to choose which one. And it's actually pretty expensive one too, right? So you have to make a right decision because it's cost financially too. So it ranges it ranges from the air mattress, water mattress, you have a spring mattress, your foam mattress, or a combination of spring and foam. And I tell the patient, this is what I want. So our spine has some physiological curve. So if you maintain your physiological curve in your spine while you are sleeping, that's probably the best mattress you're gonna find. But I think it's hard to find that kind of mattress. But if you use too soft of the mattress and your spine sags inside and changes your physiological curve, that's not gonna help. If you use your mattress really hard and your curve becomes straight, that also not gonna help. So I think you need a mattress soft enough that matches your physiological curve, but you don't need way softer that your spine sags inside. So I usually tell the patient, try it out like in a commercially available, go out, use it like while sleep it for a second there on the top of the mattress, see how you feel 5 to 10 minutes before you buy it. So I think for me, that's probably my individual experience. I like firm foam mattress that helps me not to sag inside the mattress, or it's just soft enough to like just matches to my physiological curve of the spine, and I feel more comfortable using those. But I think it's just my bias, but you can try it out. There's so many mattresses available commercially, but this is the point you have to remember, like how you choose it. The second question is about the shoes. um so there is so many, I mean, it's shoes available like walking shoes, running shoes. I think your physical therapist is probably the best person to let you know about your gait mechanics, your hip, knee joints, your spine relation to your pelvis, which shoes is better for you. Um, so that's probably that. And secondly, the shoes has a flat heel to the high heels. So I tell the patient like when you use a high heel, so basically you push your back part of your feet and leg up. So you're basically make your body leaning forward. So in order to stand up straight, you basically bend backwards at the lower back when you use a high heels. There are certain pathologies in your spine, in your lower back, can cause more symptoms and back pain when you bend backwards, like you have a stenosis of the canal, if you have a facet joint arthropathy, which Julianne mentioned in her talk. So that can cause more back pain. So I would try to avoid it if you have that kind of pathology, then avoid the high heels. But I think this is still case by case. I think the best person to know better for you is your physical therapist. And sometimes when you go in the shoes um, shop, they have individuals. They can actually work with you and then see you how you walk, and they can suggest some shoes for you for walking and running.
I think another common question that we get are thoughts on stem cell injections and protein-rich plasma injections. What are your thoughts, Dr. Sandhu?
To my knowledge, in the spine, there's still very little information on the efficacy of these injections. There's some anecdotal data that suggests that they can be helpful in improving pain in some subset of population, but there's currently not enough information, including no long-term outcome data that I'm aware of. We have to keep in mind that these are generally out-of-pocket costs and not covered by insurances, so you really have to weigh out the pros and cons of that sort of treatment, and then what other treatments are available to you that might be actually better investment for you. In terms of stem cell, and PRP, they're done at other joints and such also. The consumer has to be really careful about what is advertised and what is actually done, because stem cell harvesting is actually a difficult thing to do, and a lot of times what's advertised is not what actually is done. So I'd exercise caution, and I don't think we have enough information to recommend. At least I don't.
Yeah, I think that's very fair. Is running on a treadmill bad for someone with lower back pain? Does that cause more issues?
So this is another question we get very frequently too. It's a good question. So running is a good exercise, first of all. I mean, there is no doubt about it. So, but I mean, reason to have a lower back pain is varies patient to patient, and what kind of pathology you have, that kind of drives whether you're running going to make the pathology worse or it's a better option. Sometimes patient tells me that being more active, running, walking makes the pain better. For them, it's, I think, continue with the running is good option. Some patients' back pain gets worse with the impact activities, like if you have a spine fracture. And then, yes, then it becomes harder. If you keep running, your compression fracture gets worse if you have osteoporosis from it. So I would discuss with your physical therapist that, hey, this is I do have can I continue with the running or not? So there are some conditions, yes, like osteoporosis, your spine fracture, impacting activities like running can affect your can affect your lower back pain. Then I think there are other options too, like you can is basically is a matter of cardio, right? So you can try elliptical, which is non-impacting, which is also good for the joints without any impacts on the joints. You don't have impacts on the knee joints or hip joint. You can try some stationary bike too to doing cardio, and sometimes stationary bike helps because when you use a stationary bike, you bend forward, and that helps with the spinal stenosis because some patients have a spinal stenosis. They cannot walk and run longer distances, but they can definitely do stationary bike to stay healthy and stay active. But I mean, it's individual basis, and I think is as long as you like to run, and if your spine is okay as per your spine specialist, there is no reason not to discontinue it. You can continue running as long as everything is okay.
What about if there's a severe flare of back or leg pain? Are there certain activities or exercises that people should avoid?
Typically in a patient with recurrent flares of back pain, we advise avoiding activities that increase symptoms during that flare, but remaining lightly active and mobile is also very important within tolerance. Prolonged bed resting used to be the mainstay of treatment. Just a few decades ago, used to admit patients in the hospital and bed rest people for acute back pain for 7 days. But then the studies and data came out and showed that it actually worsened outcome, worsened conditioning and recovery time. So early mobility tends to be helpful for recovery. There's no special stretches or exercises that work for everyone. There's no magic exercise. It's somewhat individualized, but any mobility that's tolerated without significantly worsening your symptoms is generally considered to be safe. Other things that work during flare-ups are judicious use of medications that can help you get through that time, and heat application, things like that. So there's some things that can be done at home. But I think it's important to realize that most flares will improve. Most new flares will improve with time. It's just about getting through that time and then incorporating an exercise program that reduces long-term flare-ups.
In a similar vein, there's a person who asked a really good question of, I've tried acupuncture and physical therapy. When is it time to get an MRI? Oh, sorry, Dr. Patel, it looks like you're muted.
Okay. So if you tried acupuncture and physical therapy, and if you are getting better, then I would wait to get an MRI. If you're not getting better or getting worse during the time of you tried physical therapy and acupuncture, I think that's the time to get an MRI to make sure you're not missing any serious pathology or which is something out of the box. And also that gives us idea why you're not improving. So MRI will show you all degenerations and any age appropriate changes in the spine. So most of the people starts wearing out the disc and started having a degeneration process after the age of 40. So and Dr. Sandhu already mentioned in his presentation that some of the changes in MRI is present even without a lower back pain. So you will able to see some degenerative changes, but that's not, don't get disappointed with it because it's a nature process. It's everyone goes through that process. As long as you don't have a compression on the nerves, if you don't have any serious pathology, that pain should get better over the period of time. So I think that getting an MRI timing, yes, that's a good question. I think if you're not getting better or getting worse during even with the conservative treatment, I think that's the time to get an MRI.
Going back to a little bit at the beginning, what are some preventative measures to avoid all of this from happening, to avoid the back pain and leg pain?
Sometimes recurrent pain is not avoidable. It's just sort of a fact of nature. Hair falls off, wrinkles happen. It's just a fact of nature. When someone has recurrent back and leg pain, we try and rule out any concerning causes and exam findings, and then see if a routine PT and exercise program, independent program, can be established. People who exercise routinely, and there's tons of data to support this, they tend to experience less frequent symptoms. Their flare-ups are less intense, whether it be back pain or sciatica. The other things to work on that I touched on in my lecture include maintaining a healthy body weight, tobacco cessation, healthy diet practices, healthy posture, kind of work ergonomics, exercise ergonomics, and things like that. So things sort of, outside of just stretching. If it's due to a pinched nerve and things are just kind of recalcitrant, maybe looking at imaging and considering injection and surgical options can be considered also to complement your symptoms or improvement in symptoms.
Yeah. Dr. Patel, I think you kind of reviewed this earlier, but can you review what the goal of spinal decompression is? And I think you are still muted again. You're very good at being polite.
So I think the goal for spinal decompression is to making like whenever compression on the nerves, just to make room or room around the nerves. So that's the primary goal. So this can be achieved by different methods. I mean, you can try conservatively. You can talk to your physical therapist and chiropractor by gentle manipulations and lumbar traction that can help with the open up the holes, foraminers for your nerves. But usually it's not long lasting, can relieve your symptoms temporarily. And if you're not get better, and if you're talking about surgical decompression goals, then these are the goal is the same, to make room around the nerves and improve your symptoms which caused by the nerve compression, like sciatica pain mainly in the leg. The symptoms your tolerance to stand a long time and the walking tolerance improvement. So these are the goal. But I think it depends on which particular pathology you're getting a spinal decompression. So I think that still becomes a discussion with the surgeon about like which symptoms going to get better, which symptoms going to stay, and then getting an expectation set up, your goal set up before the surgery. And you might have some residual symptoms after the surgery, but that still is not disappointing. I mean, don't get disappointed with that, because it still can be treated with the physical therapy and other conservative methods, what are the leftover symptoms you have. But I think it's the main goal is to get room around the nerves and get the symptoms better, which are the caused by the nerve compression, but still you have to talk to your surgeon about your final goals, like for this particular spine decompression.
Great. Thank you, everyone. I want to just wrap us up. It's now 1 o'clock. Thank you to our 3 presenters, such great information. We're going to have, this is a recorded webinar, so we'll send out an email later in the week and you can view this again or share it with anyone who you think might be interested. And of course, you can always go on to uwmedicine.org and learn some more. Thank you. Thank you, everybody.